Top Med Talk.
Well, hello and welcome to Top Med Talk. I'm Desiree, Chappell, your host, and I'm joined by my co-host, Monty Mythen. Hello, Monty.
Good morning, Desiree. Welcome back to UCL for day 3 of EBPOM 2022.
The World Congress of Perioperative Medicine. Monty, how does it feel to be in person for this meeting?
It's great. And it is a truly world congress. You know, we have 4 corners of the globe represented in the room, which is wonderful. Yep. Lots of different voices heard, particularly the abstract competition, which was excellent, final today. But, very difficult choices to be made there. So some wonderful abstracts.
Yes, they really are. Well, Monty, we have been at it for 3 days now. This is day 3. We're wrapping things up. Some of your highlights from this last couple of days.
Well, so I would say 2 things I want to highlight from yesterday. One is the return of the great world fluid debate.
Yes.
Given by the wonderful Dr. John Myberg, Professor John Myberg from Sydney in Australia, who's been a major contributor to trials in this space, but of note, particularly trials in the established critically ill patient.
Yes.
We'll come back to that in a moment, I'm sure. And the other thing was we revisited the POCI, the Perioperative Quality Initiative guidelines. Yeah. And there was some emphasis in particular, lots of questions about the blood pressure guideline, which highlighted intraoperative hypotension as an indicator of quite severe hemodynamic instability. And in that paper, published a number of years ago, we highlighted that one of the potential unintended consequences would be the use of vasopressors, which is an easy way to correct blood pressure intraoperatively, as opposed to correcting the whole hemodynamic profile. You know, do they have a volume need? Do they have an afterload need? Do they have a contractility need? Do they need their anesthetic turned down should someone stop pressing on something? Right. And, recently we've seen some large reports, particularly from America, of what we feared, less fluid being given, more vasopressors being given in tens of thousands of patients, and more acute kidney injury. So we're remarkably good at delivering the unintended consequence. Hopefully, we know in parallel with that, there's very, very many centres, and we heard about some of them here, have taken the alternative approach, and they've pretty much eliminated acute kidney injury, which means that the suggestion that it's now a hospital-acquired condition, as opposed to a manifestation of a disease process, is really worth reflecting on. And the final thing's, giving a long speech here, the final thing, you did ask.
I did ask the question.
The final thing is, in revisiting the Great World Fluid debate, the big takeaway was, based on trials of tens of thousands of patients now, is that using a balanced and buffered electrolyte solution like lactated ringers is a pragmatic first choice unless there are contraindications. That context, which we'll come back to, I'm sure, in our discussion to follow, is really, really important. Yeah. You can't take critical care literature and apply it in the operating room. You can't take elective surgical data and apply it in trauma or the emergency patient. Right. They're all unique situations which we must be mindful of. And the final thing is it remains that, as John expressed it, it's been said many different ways, the sweet spot of the U-shaped curve, the Goldilocks ambition, just right is where we are looking for. And once you're a litre or 2 up in any sort of situation, you don't need to be more than that. Yeah. You may need to be that, just for issues I'm sure we're going to discuss in a moment. But there's no situation where you need to be more than that. Right. So we're seeking that sweet spot, which is about plus 1 or 2 litres. But fluid excess is very, very harmful. Yeah.
Well, and then I was in the great fluid debate and coming from the angle of the OR with surgical patients, not necessarily just critical care. So for me, it was really important to understand the nuances of translating that into, or not trying to assume too much for the OR, and also bringing it home as to, hey, this is what's actually happening on the ground right now because of everything this debate and everything we've been talking about. And I think a perfect example is in the U.S., enhanced recovery in the last 5 years has really taken off. And in many of our enhanced recovery protocols, we're seeing some of the language that's been used along the way in some of in previous reports and literature. And so I think that's kind of where how we're ended up where we are right now.
So, and we saw that, and I keep banging on about it, but when we had a national program in the UK, which finished in 2012, we saw a rise in acute kidney injury in the types of patients that we were implying enhanced recovery in that you could see at a national level. So it was in the national statistics, there was a spike.
Yeah.
And on reflection, we'd look back and people had said, the new enhanced recovery program said avoid fluid excess and use a goal-directed approach, which doesn't necessarily mean using a monitor, but seek out the Goldilocks point, if you see what I mean. And that got translated in many guidelines to fluid restrict.
Right.
And we're also saying, which we've heard more recently, that when we say it's okay, as we wrote up in our recovery guidelines, which corrected the problem, it's okay to be 1 or 2 litres positive at the end of a big case.
Yeah.
That some people took that away and said you should not give more than 1 or 2 litres in a big case. So we're still fighting that huge variation in interpretation of literature that's hard to interpret.
Yeah, absolutely. Well, enough of us banging on, Monty. People get to hear us all the time. So further to this conversation, we want to introduce our next guest, who I've been dying to actually talk to and meet for years and years. But Birgitte Brandstrup, she's from Helbeck Hospital, part of the Copenhagen University. Birgitte, thank you so much for joining us today.
You're welcome.
We were so excited whenever we learned that you were going to be here. You've heard our conversation now. We had lots of conversations over the last day about the great fluid debate, and you were part of that yesterday and participated in that. Kind of just an overview of how you feel about the conversations that we had yesterday. Where are you at on that?
I think that somehow my mission is accomplished because everybody is now preaching what I was preaching to begin with. But also I think it's extremely important to keep context. Mm-hmm. And I fully agree when Monty is saying that you should not mix up intensive care with the wards, with perioperative anesthesia, and with emergency medicine. And they probably need different approaches, and that's very important to stress.
So take us back. Tell us a little bit about yourself and the research that you've been doing.
All right. I am a clinical associate research professor at the Copenhagen University Hospital, and I've been working with intravenous fluids since the last millennium.
Wonderful thesis.
Well, and I guess that restrict fluids is on me, because in the first trial we had fluid restriction versus standard. Mm-hmm. But at that time, it was common that our patients were fluid overloaded with between 4 and 6 kilograms, or liters, if you like, immediately postoperative. And pulmonary congestion and pulmonary edema, ARDS, were commonplace. So as a young doctor, we often had furosemide in our pockets in the white coats, so we could give the patients furosemide on day 2 and 3 postoperatively, because that was where the symptoms emerged. So we asked ourselves, is this really a very good strategy for the patients? And on the same time, Randi Beyer-Holgersen, she made a trial of early nutrition. And when you make a nutrition study, you really measure body weight and stuff. So she found that those who gained the most weight in her trial were those with the worst outcomes. And it was in particular anastomotic leak. Mm. So we formed the hypothesis that fluid overloading has a downside, and we proved that to be right. So at that time, fluid restriction was compared to the standard treatment with a fluid overload of 5-6 liters. And what we did was we strived against a zero balance, what we allowed +1 in the postoperative phase. And that was what brought the good results of the first trial. In the next trial, I compared the fluid restriction. At that time, restrict was well, I won't say misunderstood, because it's a matter of, well,
Context.
I'm not a native English or American person, so if you understand it as not give fluids when it's needed, then that's not the page I'm on.
Yeah.
So I re-baptized it to be zero fluid balance. That was more accurate. That was still what we were striving for in the perioperative in the operative theater. But again, we allowed a positive fluid balance of up to 2 kilograms in the postoperative period. And you have to remember also that one shoe doesn't fit all, because this is colorectal patients, and they have an intestinal paralysis postoperatively, collecting fluid in their intestines, causing a weight gain. I'm not sure that a heart surgical or a breast surgical patient has the same issues. So for them, it might be a little bit different. And again, early feeding has been part of all our trials. And free drinking immediately postoperative when it was safe to swallow has also been part of all our trials. So if you have a regime, for example, in stomach surgery, where you make a ventricular resection and you prevent the patient to eat and drink postoperatively, you have to take that into account in the regime. And frankly, I think anesthesiologists a little bit mix up things when they say surgery is surgery, because the postoperative course for the patients are very, very different. And colorectal surgical patients have for a long time now been allowed to eat and drink postoperatively, while upper GI surgery has not had the same benefit. In fact, it has never been tested, and that's really something to work on. Yeah. Unfortunately, I don't have those patients, so I can't do the trial. But I really recommend that somebody should try to see if continuous fasting and use of nasogastric tubes is really necessary in patients who had a biliary resection or whatever. Yeah.
And you know what we never said? You are not you can say that about anesthesiology because you're not an anesthetist, correct?
That's correct. I'm a surgeon.
Yeah.
And why do a surgeon take interest in fluid therapy? It's because I have the patients with a gut that's not functioning.
Yeah.
So we have to have the intravenous therapy correct.
Yeah.
So you're rounding on your patients on the floor post-operatively. For those of us who do or did surgical intensive care or surgical high dependency, we see much of what you see too, if you see what I mean, in a slightly different context. But we see a lot of what our anesthesia colleagues may not see if they don't round on their patients post-operatively. As you said earlier, it's that day 2, day 3 is where the fluid balance plays out.
That's right.
Yeah, which I think is common practice. You know, we mentioned that with enhanced recovery, we've seen this a lot, and a lot of institutions, that I'm speaking from U.S., have been adopting this in the last 4 to 5 years. And during that time, production pressures have also gone up, and the number of clinicians that actually do rounding on their patients post-operatively has gone way down. So we're not necessarily seeing the direct impact of what we're doing in the OR. And I think that has, definitely a detriment to our practice, because in the days of you go around, you see, they had to put their NG tube or the difference between pre-ERAS and post-ERAS and how wonderful that they looked, or that they're just sitting in bed looking absolutely miserable. We just don't see that anymore. I think it's hard.
Yeah, I really do believe that's why we have to work together in the specialties, because we have a lot to learn from each other. And also, you were mentioning the AKI. I have never advocated that you should not monitor urinary outcome. And again, that's context, because I've said for a long time that during the surgery, the stress response, the hypertension, etc., the anesthesiologist should not be much concerned about a very low diuresis during the surgery.
Yeah.
But after surgery, We need to monitor the diuresis, and we need to make sure that the kidneys are doing well. And if the diuresis is low, we have to examine the patient and find out what caused it. Because if it is hypovolemia, you should, of course, give a fluid that treats hypovolemia, and that's a fluid that contains salt. It could be a Ringer's or it could be normal saline. However, if it's lack of water, then the treatment is not extracellular volume, it is water. And the intravenous water is actually glucose.
Can we hover on that one for a second? Because often that sloppy language is used to say the patient's a bit dry, and then you have to say, I'm sorry, what do you mean? Are you saying dry to mean hypovolemic, or are you saying dry to mean dehydration? Because both states can exist.
Exactly.
In that patient, either coexist or independently exist.
That's right.
So how do you determine that at the bedside? How do you differentiate between the two?
When I'm teaching my students and other people with interest in fluid therapy, then I have a slide showing the differences between the two. Hypovolemia means lack of water and salt. This is extracellular volume deficit. And it can be caused by bleeding, then there's an additional loss of red blood cells, etc. It could also be from severe diarrhea, like cholera or something. You die from hypovolemia if you have a severe diarrhea. Or a stomal output from a new formed ileostomy, a high output stoma. On the other hand, you have the dehydration that actually kills a lot of people every year, especially elderly people in warm countries. And the symptoms of the two differs. The symptoms of hypovolemia is circulatory. It's the blood pressure, pulse, etc. you see. The symptoms of dehydration is cerebral. So you see confusion, dementia, even coma if it's really severe. And it is followed by increase in sodium, increase in proteins, etc. And you need to know also the normal fluid losses that we have, including insensible perspiration and urinary output. And you need to know the pathological fluid losses that our patients have, because we shouldn't find them around this table, I guess. but that's the ileostomy output, the emesis from postoperative paralytic ileus or whatever.
So my initial approach on the SIC with a recovering patient is initially, we're going to look at the fluid balance as part of our rounding anyway, is if they say that they feel thirsty and, combined with that, their sodium is elevated, people say, well, they've had loads of fluid. I said, well, you can be salt and water overloaded and dehydrated.
Exactly. And you have really to differ between the two. Insensible perspiration is the only water loss, clean water loss that we have in the body. And it's about 10 mils per kilo per day. And very constant, actually. So you have to say that about a liter is pure water loss. And you should not replace that with saline. Because the message is you have to replace loss with the same volume and a fluid that mimics the electrolyte lost.
We're going to bang on about this a little bit. If saline is dehydrating to the cell, potentially, because if it's hyperosmolar and the sodium elevates, it can actually produce intracellular dehydration. And people say, "Whoa, you can't need." Don't tell me that. You say, "Well, try it." If you end up being hypersalinated and therefore your osmoles are up and your sodium's up, you'll be thirsty and your cells will be shrinking.
You need to know your basal physiology. And there's a reason why we can't drink seawater. And that is because the kidney's ability to excrete saline, it is maximal 300 millimoles per liter urine. And that we know from trials going on just after the Second World War. They placed 19 years old, the young men, on a rack outside the coast of Australia and monitored their urine, got the references. So we know it. And they were sitting there for 3 days without anything to drink. And the maximal sodium output was 300.
So I haven't done it for a while because we'll get off this in a second. But
yeah.
It's a bit, because I haven't taught the medical students for a good while. But as part of my opening workshop, we used to just taste the IV fluids. Because if you get a bag of saline, you work up from 5% dextrose, which is a quite nice sugary water, up through whatever you call D5 half, if you see what I mean, which is a bit like a sort of sports drinky thing, up through lactated ringers, which is almost already completely intolerable, back up to saline, which is essentially quite light seawater. It will make you barf if you're not careful. It's quite sticks with you, that one.
Yeah, it does.
That sticks with. I don't make them drink the urine anymore. That's when I was a medical student.
Let's say you probably get in trouble for that one now. Well, so I do want to move on, but listening to this, is there an easy button of what should be your guidance, post-operatively to manage fluids?
Yes, there's an easy guidance. It is you have to divide your fluid charts in two. The normal needs, and that is about 100 millimoles of sodium, about 60 millimoles of potassium, about the brain's basic metabolism for glucose is 150 grams or 850 millimoles, and about 2 liters of water. That should supply daily needs in most people around 80 kilograms or so. And if you have a patient that is fasting or for other reasons not allowed to drink, this is what you should give them for their basic daily needs.
So if they're MPO, like nothing by mouth, that's what they get.
Yeah, right. And if they have pathological losses, aspiration, high output stoma, whatever it might be, blood loss, then you should replace it with something that's relevant for the loss. And here I would like to say a little bit about aspiration. Because if you have a hyperemesis in your pregnancy, then your aspiration is coming from the ventricle and it's hypotonic. But if you have ileus, the fluid is coming from down your intestines, and it's a secretion from the small bowel, from the pancreas, from the bile, from the stomach, everything. So it's isotonic, and that's a difference. And if you have a postoperative paralysis, then it's the isotonic fluid you are losing. So you have to give saline for that. Then you lose from the ventricle a lot of acid. Mm-hmm. And the body compensates this by expelling kalium. Mm-hmm. But you can give a lot of potassium, sorry.
I was going to say potassium, right?
Potassium.
Ventricle is what we call the stomach.
Yeah.
Sorry. Well.
It's okay. It's okay.
Thank you for the corrections. The important thing is that I get understood.
It's translation.
Potassium. Anyway, potassium is difficult to administer intravenously because it gives you phlebitis and you have cardiac side effects. So I'd like to give, what do you call that, a recommendation that is non-approved. Block the loss of acid with a proton inhibitor.
Mm-hmm. Yeah. Big acid difference, big pH difference, huge.
Yes, very. So every time I have a patient who has a prolonged or paralysis postoperatively, I give them pantoprazole. And if they come from at home with a PPI already, I give them 80 mils times 2 intravenously. If they don't, I give them 40 milligrams times 2 intravenously. Then you don't need to speculate about the acid loss and the potassium. You just need to replace the aspiration with saline, volume for volume.
Great idea.
That is so interesting. Okay.
Off-label is called. Sorry, I forgot the word.
Well, a lot of a lot of people that are having GI symptoms are usually put on a PPI. I feel like.
Not necessarily the group you're referring to.
No.
I mean, the unblocked, if they've got a stimulus to if they're smelling food and things like that, the pH might be 2 in the stomach. If you block it, it might be 7.
Yeah.
Yeah. And so in my patients, they get the PPI not for prevention of ulcers.
No.
But for prevention of acid loss.
Yeah.
And thereby prevention of potassium loss.
Yeah.
And that group
Secondary.
that does get that metabolic alkalosis as a result of the acid loss
Right.
is one of those indications for the use of normal saline because it's acidifying.
Well, yes and no, because it doesn't contain the potassium that they need to correct.
Sorry, with potassium stuff. But I mean,
Right.
if when one gets into debate as when do you ever see a patient with a metabolic alkalosis, it's that upper GI loss group is where you can see a metabolic alkalosis.
Exactly. Yeah. And you can prevent it with an early good treatment.
Yeah, that's interesting.
Yeah.
So, could talk about this for a lot longer, but in the interest of time, two things that I want to kind of go through and hit on just a little bit deeper. The first being the conversation about the context in the theater, in the OR, with the surgical patient, and in the state of low volume because we're not giving a ton, we're fluid restricting, and we're doing more of the vasopressors. I mean, where do you think we need to go? Like, how do we start changing that thought? Because in the U.S., it's all about hypotension now, avoiding hypotension, not giving a lot of fluid and giving so much vasopressor, and we just keep adding it and going up and up and up.
Well, we just made a trial on emergency surgical patients because I really believed that the goal-directed fluid therapy of near-maximal stroke volume was a good approach for these patients. And that is because they are in imbalance with fluids as they arrive to hospital. Mm-hmm. They had ileus, they had vomiting, they had perforation of the gastrointestinal tract. Some of them are septic. And I really believe that was a very good approach. And the stroke volume optimization has the ability that the pressure-guided fluid therapy do not have to tell you when you can stop the infusions. Because when you are near the top of the starting curve, then you can stop the infusions. Mm-hmm. In the early trials, they didn't do that. They just kept pushing with saline.
Yeah.
But that's actually an ability that you have. So we made a trial like that where we optimized them and then we stopped the infusions. We had a very low background infusion of 2 ml per kilo per hour. But then we stopped the volume therapy. And if they dropped again, we optimized them once more. And the control group were given the pressure-guided fluid therapy, again striving about 1+ or so, because this was major emergency surgical patients. So we had
an abdominal, right?
Abdominal. It was only gastrointestinal perforations or bowel obstruction.
Right. Sorry.
So. And to our big surprise, there was no difference in outcome between the groups. On the contrary, the goal-directed group had 1 day longer hospital stay, which was significant. So what to do? I think we need to get more back to basics, that we need to look at our patients. We have to make our best guess on what are their loss preoperatively, and then replace that. If you receive a patient with small bowel obstruction, how long did it last? How many times did you vomit, etc., etc.? Then you can, if the patient do not have circulatory symptoms, you know that less than 20% of the extracellular volume has been lost. And typically you have an extracellular volume of about 3 liters. So then give 1 or perhaps even 2, but stop there, because if the patient had lost 3, you would see it in the hemodynamic parameters. And then go for zero balance or +1 afterwards.
Yeah. Monty, what were you thinking whenever you heard that yesterday?
I think it's very important. I mean, we know, I was just checking the Floella trial, which is the multicenter trial in the UK, has recruited over 2,300 patients now, so it's close to having a result using multi-technology and a goal-directed approach compared to standard of care. So that's going to be interesting to see where that goes. My hunch would be that you'd find results that Birgitte's suggesting is when you've got a situation where there's quite a lot of inflammation and early sepsis going on.
Yeah.
You're not in the elective OR state.
Right.
You're more towards that ICU state. You've probably got what we used to incorrectly call leaky capillaries, but it works as a bedside sort of suggestion. You probably do need fluid resuscitation, but you will continue to give it and give it and give it and give it because the body will just distribute it.
Yeah.
And you have to put the brakes on when you're certain that you're reasonable chance that you're up a little bit. And then you probably have to use the early use of vasoactive agents to stabilize the hemodynamics if you're symptomatic. So I think we just need to do a lot more work in the space. But first principles, you know, if you have probably lost your glycocalyx or you've got a rapid, slightly high right-sided pressure, everything you give is going to pour out once you've reached a point of adequate resuscitation. So well done for doing the trial. Great result. So.
Thank you. Yeah. Well, I have to say I must have very skilled anesthesiologists because you can.
It is pretty impressive.
You can put it the other way and say they're so skilled they don't need this additional.
Yeah, well, I mean, I think that's a very, very good point.
Yeah,
because in using the more advanced monitoring technique, I think all you're trying to do is to allow everybody to be as good as the top 20%. Because there's the top 20% are just naturally very good at getting it right. Mm-hmm. It's a bit like playing different types of complex sports. Mm-hmm. But we're not all that good. So some of us need lane control and we need sat-nav and we need guides and nudges. Because we go too far one way or t'other. But I think you might be lucky.
And the GPS to go from A to B.
So you may just have great, I'm sure you do have just great colleagues. Big shout out to them.
Yeah, absolutely. Well, I mean, obviously you've been talking about this is something that you've worked on and this message has been around for a while. So people are thinking about that more.
But the interesting thing in that trial with the emergency surgical patient was that, again, when it came to cardiopulmonic complications postoperatively, the sweet spot was around zero balance. However, when it came to kidney complications postoperatively, the sweet spot was around plus 2 liter balance. So therefore we recommend no more than plus 2. But on the other hand, go somewhere in between there. But again, context. This is emergency surgical patients.
Yeah. No, very, very important point. Okay, so wrapping up or coming back to where we started is if you were to tell a new provider or clinician, anesthesia, surgical colleague, about how to manage their fluid in the context of enhanced recovery for the surgical patient, what would you tell them?
I would tell them, firstly, your patients are not dehydrated to begin with if they kept the modern fasting regime. Secondly, replace loss, volume for volume, and have a background infusion of about 2 ml or something. Not more.
Yeah.
Probably less in many times. Anyway, it depends on the surgery, what it is and how long it's lasting. And next, allow the patient to return to normal as fast as possible. Give them something to drink and eat if they want it. But if it is major surgery, it's very important that the surgeons are ready to grab these patients, to catch them up. Because if they're used to have severely overhydrated patients, their thoughts are not to give them the fluid they need. Their thoughts are to try to get some of the fluid out of them and perhaps put them in a dry spot somewhere. However, if you do the restricted fluid therapy, or zero balance or +1, +2 balance, whatever we should call it nowadays, meaning the same thing, then the surgeons need to continue the good work and again replace the loss volume for volume with what the patient needs. And remember, there's normal losses that everybody has, and there's pathological losses. And remember to replace both of them.
I think that's fair. So Henrik Kellett, a fellow surgeon, different, but fellow, said in the context of enhanced recovery, it's not fluid restrictive, just avoid fluid overload.
That's true. I agree.
Yeah.
And
enough guardrails on that to know?
Oh, I think that's good. I mean, they're nice, simple, should be simple takeaway messages. Mm-hmm. And I think, and the other thing, because we saw a lot of patients coming back under resuscitated. Mm-hmm. The other thing is, if you see a patient comes back who's not +1 to +2, do a serious bedside reevaluation to say what has gone on here. That means that they've arrived back post-op, not a little bit up. And sometimes they're quite a lot down. But that's,
yeah.
We've all got different, we want to be in that Goldilocks area.
Yeah. And one more.
And don't forget hydration.
Yeah, hydration.
Yeah.
Andy Shaw said stick an ultrasound probe and do a point of care ultrasound on the IVC.
That may become much, much more common.
But that's again from hypovolemia.
Yeah, not hydration.
It's good.
Not dehydrating.
So we found it's quite hard to get, it's probably a lot easier for you as a rounding surgeon, quite hard to get people to switch post-operatively to rehanging if the patient has been well resuscitated and they're doing well. If they do need some IV fluid, they probably need a hypotonic maintenance fluid if they don't need replacement or resuscitation. That was actually quite hard to reintroduce because people were very fearful somehow that the patients would end up with severe hyponatremia and start fitting because they'd become so fearful of water. But we got through that by a long quality improvement program. And the patients feel less thirsty and they pee more.
Yeah, that's right. And both we want. And don't forget the nutrition.
That's right. That's right.
Stops you getting cold at night.
Yeah. Birgitte, thank you so much for sitting down with us and having this conversation. Appreciate everything that you have done throughout your entire career and everything you continue to do. We look forward to seeing more. Thank you so much.
You're welcome. Thank you.
Top Med Talk.
All right. Well, thanks for listening to Top Med Talk. You can always find us on your favorite podcatcher. We are on social media, LinkedIn, Facebook, Twitter. We are there. Be sure to give shout outs whenever you like something that you hear. Share with your friends. And if there's a certain topic that you want to hear more about, let us know. Thanks so much for listening. Check out topmedtalk.com, live.ebpom.org, all of those good things. We'll talk to you later. Cheers.
Bye-bye.